Hello everyone, my name is Sarah Jones and I teach health and physical education to kindergarten through 6th grade students at East Petersburg Elementary School, part of the Hempfield School District in Lancaster, PA. This is my last class for the program. I chose the topic Diagnosing Developmental Disabilities because the process is one of interest to me, especially teaching at the elementary level. This presentation will outline the major streams of development as well as atypical patterns and details involving the diagnostic evaluation. This text specifically focuses on the developmental disabilities caused by brain dysfunction, not sensory deficits. Lack of attaining cognitive, motor, or social adaptive milestones, or the presence of aberrant behaviors are the major reasons that a child will undergo developmental diagnostic evaluation. Sometimes the concerns are raised by parents, but often more than one person, such as a caregiver, are included in the surveillance and screening. The diagnostic process aims to identify answers to 4 fundamental questions. What is wrong with my child? This is the diagnosis. What is going to happen to my child? This is the natural history and prognosis. What can be done to improve my child's condition? This is the treatment. And what has caused my child's condition? This is the etiology. The critical thinking activity is to determine whether the following statements about the prevalence of developmental disabilities in children, 1997 through 2008, are true or false. Disabilities are common in 1 in 6 children in the U.S. This is a true statement. The prevalence of ADHD was 12.69%. This is false. The prevalence was actually 6.69%. The prevalence of autism has increased 289.5%. This is a true statement. Autism prevalence increased 289.5% in the 12-year study. Females had twice the prevalence of any developmental disability than males. This is false. Males had twice the prevalence of any developmental disability than females. Specifically, higher prevalence of ADHD, autism, learning disabilities, stuttering, stammering, and other developmental disabilities. Children from families with income below the federal poverty level had a higher prevalence of developmental disabilities. This is a true statement. Let's take a moment to define development and the 3 primary streams of development. Development is actually an end product or neural function that unfolds over time. The CDC describes developmental disabilities as a group of conditions due to an impairment in physical, learning, language, or behavior areas that begin during the developmental period and typically last through a person's lifetime. The CDC lists some of the commonly diagnosed developmental disabilities as ADHD, autism spectrum disorder, cerebral palsy, hearing loss, intellectual disability, learning disability, vision impairment, or other developmental delays. Development is both quantifiable milestones and qualitative features. The 3 streams of development are motor, relating to the gross and fine motor skills and oral motor function, cognitive, relating to the receptive and expressive language abilities and problem solving, and neurobehavioral, relating to social and emotional behavior, self-regulation, and mental status. The streams of development pictured here from the text illustrates the streams of development and their areas of independent analysis. Arnold Jessel observed in his research that typical development is methodical, orderly, sequential, timed, and therefore largely predictable. His schedule principle uses milestones and tests as markers for neuromaturation. The 3 terms are often used to identify underlying brain dysfunction are delay, disassociation, and deviance. Developmental delay means that a child experiences a significant lag in 1 or more areas of development. The milestones are still achieved in a sequence but at a slower rate. If you're extremely interested in the procedures of determining significance, check out page 245 of the text for all of the riveting formulas, including direct quotients and figuring of developmental age. Understand, though, that the fancy formula is necessary to figuring the percentage of delay or progression. One aspect of determining the formula that I really appreciate is the variety of texts and research taken into account to attain an accurate number, such as tables of normal milestones, review articles, and a plethora of assessment instruments. Developmental disassociation means that the child experiences a significant difference between two or more of the major areas of development. Typical sequences of development remain, but one or more area of development is out of phase with the other areas. Standards of measurement are used again to determine the rate of discrepancy between academic achievement and intellectual ability. This association is important in defining and distinguishing various developmental diagnoses. Developmental deviance means that there is a non-sequential unevenness in the achievement of milestones between one or more streams of development. Deviance is untypical for any age, and it's often described qualitatively rather than quantitatively. Global development delay is not widely used to classify but refers to significant delays in two or more of the following delays: gross motor or fine motor, speech and language, cognition, social personal, and activities of daily living. Basically saying delays in two domains is the same as a general delay. Global developmental delay specifically addresses significant delays in language and cognition and typically have deficits in daily living too. Developmental regression is the loss of a previously attained milestone. Spectrum disabilities refer to disorders that have spectrum of severity and prevalence, such as dyslexia or specific reading disability, developmental coordination disorder, ADHD, cerebral palsy, intellectual disability. The severity, or where the student lies on the spectrum, is determined by the degree of delay, disassociation, and deviancy. Developmental disabilities have observable manifestations in cognitive, motor, and neurobehavioral functioning. The continuum of developmental disabilities refers to additional impairments or coexisting disorders. The iceberg image is used to describe the developmental profile. The primary diagnosis is seen above the surface, while the larger continuum of manifestations and underlying brain dysfunction lie below the surface. Diagnosing is critical in treatment planning, prognostication, and clinical care, as well as identification of resources and research. Most often, diagnosis is described as disorders or symptom cluster syndromes. Even with diagnosis, developmental disorders can have many different causes. The levels of diagnosis include specific impairments, categorical diagnosis, and etiologic diagnosis. Specific impairments identify pertinent signs and symptoms and is the prerequisite for the next level, categorical diagnosis. This level is critical in treatment planning. Often a target system approach is used to treat because each child is different. When planning for treatment, one must consider the abilities and the environmental impact. A common classification system used is the International Classification of Functioning, Disability, and Health for Children and Youth, ICFCY. Categorical diagnosis looks closer at disorders and symptom cluster syndromes. It's the primary way that the developmental disability diagnoses are classified. Knowing this level of diagnosis is critical in guiding treatment, identifying association problems, providing a prognosis, and communication information to those involved with the student. Etiologic diagnosis identifies any specific underlying cause of the developmental disorder. This level of diagnosis is often identified in more severe brain-based developmental disabilities. The following table identifies how the three levels of diagnosis flow together with significance. The diagnostic process often starts with the symptoms and concerns or the chief complaint. The age of referral to the specialist is often tied back to the actual developmental diagnosis. Depending on local resources or preferences, the diagnostic evaluation will either use a multidisciplinary team that specializes in developmental disabilities or an individual clinician, such as a neurodevelopmental pediatrician or a pediatric psychologist. Regardless of who's involved, the process should include the following elements: a caregiver interview, including thorough medical history and review of symptoms, developmental and behavioral history, social history, and family history. More on this later. Review of pertinent medical and educational records, such as standardized tests conducted by specialists. Direction, clinical assessment, such as a physical examination, developmental or psychological testing, and neurobehavioral examination. Determination of categorical diagnosis, typically using criteria from Diagnostic and Statistical Manual of Mental Disorders or International Classification of Diseases. Consideration of etiological possibilities. History. Gathering information from a variety of categories is critical in the process of diagnosis. The four major categories of history include medical, developmental and behavioral, family, and social history. A complete medical history must be gathered and evaluated, including a prenatal and perinatal, to identify risk factors and markers of fetal abnormality, neonatal complications or treatments, and the evidence of nonspecific neurobehavioral or neuromotor abnormalities related to the central nervous system, and postnatal to establish risk and clues to development of problems. The gathering of this information often includes specific prompts so no information is missed. Gathering developmental and behavioral history requires more than surveys and prompts. It requires substantial skill, experience, and time. It's usually the most informative aspect of the neurodevelopmental diagnostic assessment. There's a table in the text, table 15.5, and it demonstrates the components of developmental and behavioral history with the developmental milestones as the cornerstones, providing the necessary information to identify developmental delays and atypical patterns such as dissociation, deviance, and regression discussed earlier. The clinician will choose to focus on appropriate milestones in relation to the age of the child when gathering this type of history. The text gives an example of eliciting expressive language history. An infant would require defining babbling to a parent, where a 3-year-old would require meaningful spoken words. More detailed questions are typically used for the current abilities being demonstrated. This means that the clinician has to have a thorough knowledge of the average age of attainment of milestones in all areas of development and the skill to help parents recall the developmental achievements, typically by connecting them to important events such as holidays, birthdays, or vacations. Using this process, a retrospective analysis of development identifies the streams, changes over time or catch-up, plateaus, and regression. Often the clinician will use standardized checklists or rating scales to gather and quantify the findings from different persons involved in the history data. After gathering all this information, it's important to determine when the chief complaints are inappropriate to the child's developmental level, also known as their developmental age. Family history should be included at least 3 generations. The primary goal is the identified genetic risks and clues specific to genetic etiology. Items to be included are parental ages at conception, history of prior fetal losses, educational levels, early educational difficulties, and major medical problems. All family and medical history should be gathered, including developmental and neurological disorders. It's even important to ask about if family members were slow learners, had special education services or extra help in school, needed a wheelchair, or any psychiatric conditions. Social history is trickier than one may think to gather. Parents of family members may actually be protective based on their education, cultural beliefs, family, or previous experience with students with disabilities. This may later impact their willingness to accept the diagnosis, diagnosis, and treatment recommendations. It's important to gather information of abuse or neglect, psychosocial stressors, financial or marital difficulties, mental health or substance abuse, and behavior concerns. Of course, examining the educational and habilitative intervention history is critical, such as use of early intervention services, preschool programs, and special education service, as well as details of the current educational program, including information from teachers and other school staff. Both general physical exams and neurological exams are included in the diagnostic evaluation. The specific areas of the physical exam that should be included are assessment for abnormal growth, dysformic features, evidence of visceral storage, such as hepatology, an enlarged liver, or splenomegaly, an enlarged spleen, and skin manifestations. Growth aberrations specifically provide clues for the etiology of developmental disability. Congenital anomalies should also be considered and examined, as they occur more commonly in children with developmental disabilities. If a child has 3 or more minor anomalies, they have a greater chance of also having a major anomaly, dysformic syndrome, or both. The neurologic examination often looks for markers of neuromotor maturation in infants and young children, while older children are assessed for markers of neuromaturation and neurodysfunction. The evaluation also includes direct observation and elicitation. Formal testing can be completed by the clinician, or results of testing can be reviewed. Language and non-language problem solving is measured directly. Age-appropriate, quantifiable visual motor measures are observed and recorded, as well as academic achievement. More information on the specific developmental and psychoeducational tests is detailed in Chapter 16 of our text, but basically the independent evaluations are usually brief to administer, such as the Kaput scales, Battelle Developmental Inventory, and others you see listed here. Often, portions of other measures are used, such as the Jessel developmental schedules mentioned earlier in the presentation. Adaptive functioning is measured using standardized interviews, such as the Vineland Adaptive Behavior Scales or the Adaptive Behavior Assessment, along with direct observations. Current ability to perform tasks of daily living and social roles are also measured often by criterion referenced functional measures, such as functional independence measure for children or the gross motor function classification system. Direct assessments are particularly helpful to narrow the differential diagnosis. Maladaptive behavior is quantified using standardized rating scales, such as those published by the American Academy of Pediatrics Task Force on Mental Health. One specific element to note is that the problem behaviors may not always be noted or observed in these evaluations, but this does not negate the history provided by the various members of information gathering, especially when they support each other. It's been found that many children are able to modify their behavior for a few hours, especially in one-to-one or small group settings, making evaluations and examinations once again so critical to the role of a specialist. Diagnostic formulation. Basically, all the information gathered allows the clinician to compare the specific data to scientific knowledge of normal and abnormal development and behavior, and therefore develop a hypothesis to explain the problems. This is often called differential diagnosis. This is a list of conditions consistent with the patient's history and observed signs arranged in rank, in order of decreased likelihood, often using the Oslerian paradigm of formulating a differential diagnosis. The refinement of the differential diagnosis is ongoing throughout the diagnostic testing and examinations, and in the end, ultimately emphasize one problem, even if a long list of diagnoses is appropriate. The one diagnosis should represent the most general description of that brain dysfunction. After the diagnosis, the recommendations for treatment and further evaluation are presented to the family. Usually this includes a separate specialist referrals to develop specific treatment plans. This table demonstrates a template of sorts that's created for each individual patient. In conclusion, developmental disabilities range from a spectrum or continuum of disorders. The diagnostic evaluation is the critical element in prognosis and guiding treatment planning. It involves a lot of different people, ranging from various relationships with the child to clinicians. Trained personnel must take the lead of gathering history and completing exams in order to arrive with the appropriate diagnosis. Hopefully, this information gave you a better understanding of the intricate process of diagnostic evaluation of developmental disabilities, as you may be required to complete some of the evaluations as health and physical education teacher.